Good morning. Let's go ahead and get started this morning with Grand Rounds. Dr. Zack Nash, one of our chief residents, is going to present about caustic injuries to the esophagus. Dr. Nash did his undergraduate in computer science at the University of Illinois, Urbana, and then went to medical school at the University of Oklahoma, and then is here in his general surgery residency. And what are you doing next year?
Basketball.
Basket. Really? Oh, okay.
I like abuse, sir.
All your patients will come to clinic.
Yes, exactly. Oh, which is it? One here. All right. Figure it out. All right. So this is I'm talking about caustic ingestion. This is one of the topics that actually I experienced early on when I was doing my computer science degree. My roommate swallowed unintentionally or intentionally antifreeze and was admitted to the ICU for 3 days. And then on trauma, we had actually a patient coming in, so it was kind of a near and dear. So epidemiology, it's generally a bimodal distribution. Children make up 80% worldwide, and that's usually because of unintentional ingestion. They're either messing around in the cabinets or something and find something like Drano, and we wonder what this tastes like. Those usually are not a large amount of ingestion and tend not to be as bad. The adults, on the other hand, tend to be suicidal attempts and are generally intentional and tend to have a worse prognosis and tend to be have more injury. Prevention is paramount. As we said, 80% children are involved. That's kind of why I put safety begins at home, because really locking up those cabinets, keeping an eye on the kids will prevent a lot of these. And it's really felt as underreported because a lot of places in the world have this problem, but it's not really, they don't have the resources we have here in the United States and in Europe or other well-developed countries, and a lot of people just deal with it at home and don't really come in. It's usually either the swallow an acid or an alkali, and those are the two types. And you can see down there the different things that are caustic. I have a bigger image here, things that they're around the house that we don't think about. Battery acid is very strong. As you can see here, 0, all the way to drain cleaners like Drano, and those things are very basic. The difference between acid and a base is the bases tend to be very thick, can be solid, and can sit longer on tissue, whereas the acids tend to be thinner and can usually pass by. So the pathophysiology of the injury. Acids tend to cause coagulation necrosis. It was initially thought that these would form an SR and then the penetration would be less. However, there's some recent case reports coming out with perforation injury with acid and unexpected, even with the SR in place. With significant acid ingestion, you can have renal failure, liver dysfunction, DIC, hemolysis. So it's not something you take really lightly, and these can come up later on. Alkalis cause liquefactive necrosis and saponification, tend to be higher viscosity, and that's important, as I said earlier, is because they'll sit on the tissue and can sit there longer. And really more important than just that does liquefactive necrosis is the third part, there's thrombosis. It causes venous arterial thrombosis, and it's thought that although the inflammatory response is bad, but actually that causes the ventral necrosis and an actual perforation that comes later on. And that's lots of studies in that showing that can be a real problem. And they're looking at ways to hopefully either prevent that or reverse it. So esophageal starts with the eosinophilic necrosis, swelling, hemorrhagic congestion as you expect with any inflammatory response, and then you have arterial and venous thrombosis, specifically in alkaline environment. About 4 to 7 days, you start to see mucosal sloughing. Bacterial invasion has been noticed in these. There's some studies, although the recommendations are not to use antibiotics, but some studies showed better healing with antibiotics with these patients, but the current recommendations aren't there. You start having granulation tissue and fibrin deposition, and perforation if extension past the muscular plane. So if you're in the esophagus specifically, if you start getting to the muscularis area, and there's involvement, and on these times you have risk of perforation that starts to remodel. And this is actually important because we'll talk later about workup and investigation there's reasons why they wait either early on or late because of this changes in collagen deposition and healing. And then around the 10th day, you start having repair and remodeling. So in 3 weeks, injury site is at the weakest, about 21 days. The collagen deposition begins at second week in scar retraction, and about 1 month you start having epithelialization. And that's important because you're not going to start to do really any type of dilations until after. Now, there have been documentation of doing it at 15 weeks, but that's usually in high volume centers, and it's also still high risk. What it shows over here on the slide, this is a normal esophagus here, and this is with 10% sodium hydroxide solution for 10 minutes. And you can see the murine and how it basically it causes necrosis. There was one paper talking about a 30% solution of sodium hydroxide within 1 second will cause perforation of tissue. So depending on the concentration, you can have significant injury within a very rapid amount of time. So that's also important. So presentation, now this is really the meat of it. So it's really what's swallowed. If it's solid, usually it's difficult to swallow. It'll stick to mucous membranes, and so you usually have oral pharyngeal injury. About 70% of those patients who have oral pharyngeal injury will not necessarily have esophageal or have a low level, like grade 1 esophageal or gastric injury. Although it does stuff to evaluate those, it's more likely, once they have oral pharyngeal, it's less likely to have others. And it may be due to the fact of the pain and discomfort, they usually spit it out. Liquid, easily swallowed, so you generally have more likely to have, you have increased transit time to the oral pharyngeal, but you have more injury to the esophagus and stomach. So, as I said, 70% will not have significant esophageal injury, but if you hear hoarseness or stridor, you have to really evaluate the laryngeal and epiglottis very well, because the laryngeal area and the epiglottis can be significantly inflamed. And you start really worrying about airway involvement, or not just airway, but also just airway compromise. You start thinking of esophageal injury when people complain of dysphagia, inability to swallow, and odonophagia. And you start worrying about those. And if somebody has, and you really start to see significant pain, if you start seeing epigastric pain, bleeding, hematemesis, discomfort, you start thinking of possible stomach involvement. Now, there's some also reports talking about when you can look at these differences. If alkali is swallowed, you tend to see more esophageal injury, and they think that pH, because the pH of the stomach is around 1, they think that actually will neutralize some of the base that you take down and less gastric injury. And there's also talks that if you have the acids tend to have more of a gastric injury. And the reason for that is the acid will cause pyloric spasm and have that sit in the antrum for a while, and it causes significant injury at the antrum. It's a prolonged exposure. So I can't really stress this enough. There's no pain on exam does not exclude GI injury. So if the patient comes in and has no abdominal pain, no pain at all, you can't assume that they have no injury. You have to really watch them. They can present in delayed fashion. We saw the healing process takes about a month, and so about 7 days, 10 days, it could be 3 or 4 days, dependingly, they can actually, as a remodeling, perforate. And that being said, it's unable to determine the extent of injury from the presentation alone. And they rarely on presentation you'll have actually perforation. It can happen, as I said, high enough concentration can cause, perforation rather rapidly, and those patients need to be evaluated and taken to the OR if they're presenting with peritoneal signs, and that's important too. So workup. Airway evaluation upon presentation is very important. If you see oropharyngeal lesions, and they have stridor, difficulty maintaining the airway, blind intubation is contraindicated because you'll basically, mucosa is all inflamed, you'll cause significant bleeding, you cause hemorrhage, it makes it more difficult then to subsequently intubate them. Fiber optic intubation is what they recommend. And you can hyperbolic extensive esophageal injury if you see significant airway laryngeal, you start to really evaluate the esophagus. The one thing you can do also is, if necessary, you need a surgical airway. And so that can't be off, that's definitely on the table. Although it makes reconstruction later on difficult, airway needs to be taken control of first. Really, laboratory studies have nothing's actually panned out to be predictive. What they talk about is base deficit greater than -12, and so really derangements, any metabolic derangements are significant, have higher mortality. And you can think it's longer exposure to these acids and these bases. This is longer, having sequelae from, immediate sequelae from. So this is one of those things that if you have significant derangements, they have a white count, they're looking septic, low pH, less than 7.1, they're going to have increased risk of mortality at that hospitalization. So this is a picture of basically the airway. You see the epiglottis there. What they found is, with doing these studies, that the epiglottis is really good at preventing deep airway injury. So usually they will close and prevent it, but you can see this amount of inflammation. If you try to stick an endotracheal tube into this blindly, you're going to lose your airway quickly. It'd be very difficult to do it. And so fiber optic placement, and then or surgical airway. Now I don't think I showed that picture here. Generally they'll rescope these guys, check them again, and after intubation see if these resolves. But usually these are actually healed pretty well. Radiologic workup. You look chest X-ray. You can look for mediastinal or subdiaphragmatic air, indication of esophageal perforation. You can do a gastrograph swallow, small bowel follow through, looking for again perforation as well. Now they're starting to say endoscopy, we'll talk about endoscopy in a minute, is thought to be the gold standard. But there's more data coming out that the CT scans give you better evaluation of transmural damage and actually threaten perforation. So if you do the endoscopy and you see an area that you're concerned about, the CT scan will give you an idea that this is an area that we have high risk of having a perforation from, and to actually look at it. So on part of the CT scan, they actually came out, Rio et al. 2010 came out with a grading system. Grade 1, no definite swelling or esophageal wall involvement, basically almost normal. You see some wall thickening is grade 2 without parasophageal tissue extension. And then if you have edematous wall thickening and parasophageal soft tissue infiltration, it would still have a well-demarcated margin, that's grade 3. And then when you lose that margin, it's grade 4. So you kind of see here, this would be grade 1. Really, you still see a good lining. Grade 2, you see it, but you see some kind of edematous, you still see a plane. Grade 3, there's still a plane, but you can see parasophageal involvement here. And then grade 4, you come completely gone. And you're seeing no plane between the aorta and everything there. So that's that's significant injury, and probably will need significant reconstruction, if not OR, immediately. Endoscopic ultrasound is also being used more. This tends to show, it's actually prognostic as well, but they're showing muscular, we talked about muscular involvement here, that you're losing those planes. If you have muscular involvement, the risk of having sequelae of stricture requiring reconstruction is much higher. The risk of perforation goes up as well. As I say, once you have involvement in the muscularis and you're going through that, as you start to heal, the risk of perforation from that area also increases. And so that's also will give you a lot of kind of insight. And you do this, and we'll talk about doing the endoscopic, but you generally do this within 12 to about within the first 2-3 days. So you don't really delay too much. So 12 to 48 hours, up to 92 hours, 96 hours we talked about. But anything after that is high risk of perforation. So endoscopy. So this is what was considered the gold standard. 12 to 96 hours from injury, they recommend doing it early on because you still have some of the tissue there. They still say you can pass the lesion. Somebody who's well-skilled endoscopist should do this, and to evaluate the full esophagus as well as the stomach. You don't want to do it after 96 hours because the risk of perforation goes up significantly. You're going through not as good tissue. Routine use is the question. So 10 to 30% of ingestions have no injury. Approximately 10 to 20% of asymptomatic children harbor significant lesions. So these kids may have come in with no symptoms at all, present looking fine, no identification, no gastric pain, nothing, but they harbor a significant grade 3 lesion. And then there's this, and adults, as we talked about, tend to be intentional. They also tend to have delayed presentation. So a lot of times they may sit at home and let these things soak in. And because of that, they recommend all of them be scoped because you cannot really tell the extent of injury without looking. And it considers the cornerstone of diagnosis, endoscopy. The contraindications, if you suspect a perforation, if you have a CT scan that shows you're grade 4, you wouldn't do this. If you see air on your chest X-ray, supraglottic epiglottic burns or full thickness burns to hypopharynx. And the main reason that is it's your airway. So if you're having these compromise, you need to go get your airway controlled, or you actually get your airway controlled before even considering endoscopy, because that's what you're risking there. The classifications. So next slide, I'll show you the classification examples of them. but no sequelae from 0 to 1. So basically, there's just basic erythema or no injury at all, and you generally have no problems. But once you start to go up, you have a ninefold increase in morbidity and mortality. So grade 0, of course, is normal. Grade 1, you have superficial mucosal edema and erythema. Grade 2, you have mucosal and submucosal ulcerations. And then 2A is just superficial erosion, some exudate. 2B, deep discrete circumferential ulcerations. Grade 3, you have basic transmural ulcerations, necrosis. A would be focal, extensive would be, and then 4 is frank perforation, which hopefully in your radiologic workup you'd find. And so here's the examples. So you can see grade 1 is just kind of some erythema, but nothing that it looks significant. Grade 2, this is 2A. 2B, you see significant circumferential. You have an SR here, grade 3A. This is 3A, this is B3B. And you can see that you have significant circumferential injury. So this is also, I think, an important point here. Endoscopy alone should not solely dictate surgical intervention. We have to use our clinical judgment. We have to basically evaluate the patient. They present with peritoneal signs. They present as a surgical patient. They need to be taken to the OR. What you do there we can talk about, but that they need to be evaluated from that standpoint. Endoscopy, if you evaluate endoscopy and you can take a CT scan with that as well, to evaluate the region that you're concerned for along the esophagus that shows muscularis involvement on ultrasound and look for is there full thickness or is it still plain. We'll give you an idea, one, of the risk of perforation, and two, will give you an idea of risk of sequelae from that. So I think it's not one modality, it's a multimodality as well as clinical suspicion should be played. So we talked about airway evaluation. So airway evaluation, fibrotic laryngoscopic intubation, and surgical airway if necessary. That's what you see when you see them. Hemodynamic stabilization is important. There's been data now showing that there was a prospective study about 30 patients, very small, where they showed benefit from PPI. And the thought is that the esophagus is already injured, and so the continued acid reflux that can happen from the dysmotility that occurs from this would impede healing. And they showed with their grade 3, they had 2 grade 3As that did not heal, but they had no strictures from about 18 of the split. Actually, it was the 2As and 3As, they had about 15 or so. Only 3 of those did not require further sequelae and management. So but they said still recommend further evaluation or prospective studies. And there's no evidence of benefit from steroids, although they tend to be used to hopefully stop or slow down the stricture formation as well as the inflammatory response. So the way they kind of manage grade 1 and 2A injuries on endoscopy are permitted oral intake and usually watched, make sure they don't have compromise, and within a couple of days they're discharged if they continue to well manage that. 2B and above, they recommend observation in the ICU. And nutritional support is indicated, and you would kind of watch them and see how they do, kind of, and make sure they do not either present perforation or stricture down. And that's really where it's really dictated by the patient's presentation to determine how far you progress them and how fast. So what's contraindicated? Gastric lavage and induced emesis. Although this may be something that you would think makes sense, it's counterintuitive because once you start inducing emesis, that caustic substance that's in the stomach is now going to come back and re-expose the esophagus and re-expose the pharynx. And so you're now already have damaged tissue and are re-damaging it further and deeper. So that's why that's not a good idea. pH neutralization, some thought would give if you took a base, give a weak acid, and vice versa. The problem is that it causes an exothermic reaction. You can have thermal injury now. And so you don't know the extent of how you can't really control that. And so that's really contraindicated. We talked about blind intubation, and the blind NG2 placement is also contraindicated. You should do that under direct guidance and direct visualization. One of the things that is not necessarily contraindicated, but they said is they would not do is giving charcoal. Although it's benign, it will absorb, but the reason is it makes endoscopy difficult. So you couldn't tell what's bleeding, what's not, and it makes endoscopies difficult to assess the tissue and the mucosa. So they recommend against it, but that's not necessarily contraindicated from a chemical reason. So surgical intervention. Grade 3A and above generally require surgical intervention. It's pretty close to perforation. there, or will have high stricture rate and may require that for sequelae. Perforation, obviously, from our standpoint, that's really going to need surgical intervention and control. Most likely damage control from this standpoint, with reconstruction at a later point if you can't do it at the time. Perforation based on clinical or radiologic evidence. Looking at esophagectomy with cervical esophagostomy, possibly with gastrectomy if indicated, and a feeding jejunostomy. So if you're there, you need place. We're talking about the trauma all the time. It's really important looking at feeding access, because these patients are going to be have a long course for healing, and so you need to make sure you give them the nutritional support they need. This, like I said earlier, may present in delayed fashion. So just because somebody comes in, no pain, looks good, does not mean that that person is going to be good in 3 or 4 days. And so continued high suspicion is important. And it's kind of odd, but I wrote that no role for perforation closure. The idea is that, you know, if you see a perforation, you don't just try to grab the serosa and stitch it closed, because the serosa may not indicate what the mucosa and the submucosa are looking like. They may have significant necrosis, and what you're bringing together is just serosa and not really viable tissue. So really resecting that area and getting a good view of it and bringing it together is really what they're talking about. So because you really can't evaluate what's down deep just because the serosa looks normal. I found this interesting, and there's a recommendation to attempt complete resection at the time. The problem with that is if you start having colonic extensions like that, you start taking away your options for reconstruction, like a colonic interposition and such. And so that's one of the things that you try to think of reconstruction, but if it's dead tissue, it's dead tissue. Non-viable is non-viable. They suggest re-exploration if indicated, but try to do it all in one surgical attempt. And the pediatrics, their recommendation was try to preserve the native esophagus at all costs. Try to minimize, if you can temporize it and not resect it, they recommend that, just because of the extent of long life ahead of them and the sequelae and as well as of the surgeries and such. So I brought this up just to kind of reiterate the 3A shows focal necrosis, and those are the places 3A and above is where you're looking at you're going to have surgical intervention, and watch very closely for those when somebody says, hey, I have that. So late sequelae. One, I had a patient in pediatric surgery who did this, and I was seeing him with endoscopy. We had to do bougie dilations because of significant stricture and dysphagia. So grade 2B tends 71% stricture rate, whereas grade 3 has 100% stricture rate. And then 80% form at 8 weeks from injury. And so really early, a lot of the analyses are looking at early interventions, looking at trying to minimize your inflammatory response to hopefully prevent this from happening. A lot of the problems are tractable pain, and as we talked about gastric outlet obstruction, about 5% and 6% that's pre-pyloric. Secondary due to that you call it pylorus vasospasming, spasming down, and causing antral basic sequestration of the caustic material. So with this injury to the esophagus, one of the questions was, what's the incidence of adenocarcinoma? And endocarcinoma squamous cell has about 1,000 to 3,000-fold increase in age-matched individuals. And so they will need screening and regular EGDs for evaluation. And the incidence is 2 to 30% in literature. But it's all that's from 1 to 3 decades after actual injury. And so they will need for the rest of their life just surveillance. And this doing bypass alone does not affect the incidence, and endoscopic screening is indicated in these patients. So you'd have basically now that's about, if I remember right, about 3% risk. So it's not a high risk, but it exists, and it's more so than the population. And they need to be aware of it, especially if you're talking about kids, because they will live 3 decades more. And so dysmotility is one of the other major problems associated with lower third esophageal injury, and it's thought to be autovagotomy and also delayed gastric emptying, because the left vagus at the anterior portion of the esophagus down there by the GE junction gets involved. You can take out the left vagus with that inflammation and injury, and it's thought that plays a role in pyloric relaxation and the antral motion, and that will cause dysmotility and gastric emptying problems, as well as a scar formation and will form distal esophageal dysmotility. The study has shown that that's kind of You can have low distal motility but be asymptomatic from it. You can have, but they show the esophagus never actually has normal motility after these injuries. So prevention. And so steroids still not completely defined. They haven't got a dose set up, and they really haven't seen really benefit from it. Antibiotics, there was one case study showing they had benefit from antibiotics, and the thought was that you have this wound, you have exposure to the enterics, and if you're able to, and we showed as earlier on that within a couple of days you already have bacteria in this area, that you can induce better healing, but the recommendation only was steroids at this time. And G-tube helps in these tight strictures because you maintain patency, so you can come down later and you over a wire and try to open these up. And also gives you feeding access, but not blindly. And it also can be a risk for infection. There's some studies on mitomycin and animal models of mitomycin C and other chemotherapy agents looking at of maintenance, but there's nothing been done in humans. And the problem with mitomycin is that the intact mucosa actually systemically absorbs it, and there's no dosing related to what will prevent it or not. So there's still some work on that, hopefully, to prevent these from happening. As you can imagine, these are a big deal. So stenting. This picture here is actually of a plastic stent for a different issue, but it's the only picture I could find of a stent. But they talked about silicone, rubber, or Polyflex. Has a 50% efficacy at 9 to 14 months, maintaining patency, but migrates 25%, so it's really not there. PTFE has a 72% efficacy at 9 to 14 months, and then they're now trying to use biodegradable stents that have 45% efficacy at 53 months. They migrate 10% of the time, but they haven't really been, they're still in trials and studies. They haven't really been used out there widely. So then, now you have your stricture, you look at endoscopic dilatation. The balloon or savory bougie are the options we have currently. The preference is with the savory bougies, you can actually, you have some feedback. You can feel it go down. You can feel how much pressure and extent of, how much pressure you're putting on the stricture and how much the tissue kind of relax or not. Whereas the balloon, you can't quite feel that not as easily. So the recommendation of people who don't do this on a regular basis, who are not, having high regular endoscopy, but do some EGDs, to do the bougies because you have more, feedback, and the perforation risk is less with bougies than with balloon. Avoid endoscopic dilatation for 21 days after ingestion because of increased risk of perforation, although there has been some talk about 15 days earlier, but that's in skilled centers and not really recommended. Perforation is, side 0.4 to 32% has been reported, but the actually studies shown that with experience it drops down to about 4.5%. So people who do this a lot are skilled endoscopists that have a 4.5% rate. And about 30% of these balloon dilatations have a contained perforation that resolves without intervention. And they recommend about 3 to 4 sessions with 1 to 3 week intervals in between sessions. And the kid I remember I was on his 3rd session. He had to come back again for his 4th. And hopefully with the autodilate after that, they can maintain patency. So this is the picture of basically, this is your stricture here, and then this is the balloon going through the stricture and then dilating it over a wire. So esophageal replacement, you have 2 options here, retrosternal stomach and then right colonic interposition. And then also and the question then lays, and we'll talk about after this, is whether you would do at this time esophagectomy at the time of doing this procedure or not. And these are patients that have failed any basically their esophagus is not working. They either have significant dysmotility or they have significant stricture that cannot be managed, and they failed management that way. So I'm showing here basically this is basically you bring up the stomach retrosternal and bring it up this way. The issue is, and a lot of literature talks about in terms of this procedures and stuff for cancer as well, for esophageal cancer, doing retrosternal requires more actual mobilization. About 2 to 3 centimeters more than going along we call it along the spine. And so you may need more mobilization, but the idea would be that you leave the esophagus intact and go retrosternal and reconstruct them. This is for a right colonic interposition, And you would do this also as another option. And that's why I was mentioning earlier, when you're doing your surgical resections, you want to be, sometimes you don't have a choice, but you don't want to, if you take it, you have to take your colon, then you lose some reconstruction options. So esophageal replacement, so esophagectomy, so now if you do esophagectomy, the mortality goes from 6% roughly to 11% with that procedure, with concomitant doing the reconstruction and esophagectomy. You have risk of recurrent laryngeal nerve injury doing that, of course. Everything's scarred down, the planes are no longer the way they were. And it's considered to do that in the pediatric population. And then once you get to this point, and mainly because of if you don't do esophagectomy, you lose your surveillance. You still retain that risk of having squamous cell adenocarcinoma of the esophagus, and you can no longer surveil them, so they become a high risk. And so they still have, they say 13% incidence of esophageal cancer after bypass. So it's just that initial insult gives you that risk. 50% risk of esophageal mucocele infection as well. And that's also a reason some people will go towards if it's if a patient's a good candidate. And that's the key thing, because your mortality does go up. And so you have to consider that you have a risk that what you're leaving behind may have required to come back because it's infected. So for gastric outlet obstruction, the early surgical intervention, usually greater than 3 months from injury, on average is about 6 months. Endoscopic dilatation can temporize the antrum if you try to dilate, but usually it's 3 strictures down. Pyloroplasty had about a 50% failure rate. You try to do pyloroplasty to open up, but it usually strictures right back down. You don't get much benefit. And so the safest option to talk about is a gastrojejunectomy. Just bypass that region completely. Or you can try to find just a gastro where you bring up a loop and do it, but you can also do a Billroth 2 as well. But basically gastrojejunectomy is we're talking about to bypass that stricture region to give you back put you in continuity. So we need to reconstruct. So on average, I said it was 2 months. It can 6 months, but usually from 2 months to years after injury. They've had people after 5 years being reconstructed because they were just not able to tolerate. And then you have functional success of 77% with these reconstructions, specifically the colonic interposition. Sometimes you have to take back for either for a leak or such, but they still have pretty good outcomes overall. Tracheostomy will make it difficult, not impossible, to do coloropharyngoplasty, but it is possible to do. Just to keep that in mind. But you have to do what you have to do when the patient comes in and is in airway obstruction. So, okay.
So what you're really talking about is this is a preventive disease.
Yes, sir.
As far as children go. They used to have all sorts of gadgets to try and prevent kids getting in from cabinets. And I must have gone through 10 with my son. I thought he had a great career to be a safe cracker. And probably the only thing that really works in the end is a key.
Yes.
To lock it, because all these other gizmos, the kids, you see them in the restaurants now, they're 2 years old and they're operating an iPhone. And so they sure as hell can get past all these gadgets that people think about. Dr. Cigaroa, you are here. One of your hats is a pediatric surgeon. Is this something that you've had to deal with Caustic?
Unfortunately, you actually see a lot of pediatric surgeon, probably 3 or 4 or 5 cases. I do have a question
Yes, sir.
in regards to stents.
Yes, sir.
So how are people actually managing esophageal strictures or an stent or arterial stents? And is that kind of a method of action perhaps medically or even stent to prevent fibrosis?
I didn't.
What research has been done?
I didn't see anything on medical coding when I was reading about just those specific stents. It talked about the PTFE stents having some better prevention, and it wasn't really clear whether that was because it just doesn't grow to as much or not. They sound like the biodegradable ones were still in research, or the ones that they are kind of looking for because they'll actually dissolve and go away with time, but they also had a longer patency rate. But it didn't look like overall, like 50%, as I showed earlier, that they're not necessarily preventing it. What I saw more on, we're talking about injection of some chemotherapeutic agents into the region upon initial endoscopy to prevent this migration of fibrosis altogether. So a lot of the research into prevention of fibrosis is what I've seen, more so than just stenting itself. That's a
also see preparation from
stents.
from the
Yes. Yeah.
It's not a pleasant experience.
So at least from the caustic ingestion, according to your data, there's not an early perforation.
It can.
It depends on how severe it is, but usually it's kind of a delayed phenomenon.
Yes, it can usually delay, but it can present a perforation, and that's when you take them immediately.
Have you done any transhiatal esophagectomies in children? I know how difficult it is in an adult who used to do it, and I can't imagine having to do it in a child.
I've done one in adolescent.
Mentioned weeping the native esophagus. That seems counterintuitive when you talked about that high risk of developing adeno or squamous carcinoma.
The only reason they're saying that is the mortality was about half. And so if you have a high-risk patient, if you're looking at somebody who's maybe has less than a decade or two left, the risk is probably not there. But if you're talking about a kid who's got another 50, 60 years, the risk of adenocarcinoma or squamous cell is pretty high. And so that's why they recommend in children to try and do it if you can, and in adults that you kind of weigh the options.
Dr. Armaguli.
Have you ever operated on somebody like this?
No, sir. I've just done dilatations.
The esophagus and the stomach, they look like a linitis, like a syphilitic type. It's raw, hard, it's a tube.
Yeah.
There's no contraction. What is it? We reported to the New England Surgical a few years ago from our institution, small series, and we were happy with the transverse colon interposition. The right colon is not a good idea because, number one, so floppy, and your anastomosis depend on the vein, not on the arteries. Retrosternally, you have to have enough room to put those. So transverse colon was the ideal. Even the left colon, sigmoid, you can do this. There are cases reported where they did a small bowel transposition, microanastomosis of the small bowel to the esophageal. This is done by a fellow named Cumming and a thoracic surgeon by the name of Clem Hebert. He was a product of Belsey. At the VA 2 years ago with McHale, we had a fellow who, a dancer, famous, he danced with the stars, whatever it is. Apparently in Mexico, one of his friends suggested him to cure his ulcer to take some Dranos. And he came in with the stomach, complete dysfunctional stomach. So we had to take all his stomach. It was like a leather bottle, nothing left to it. And we hooked his small bowel, the jejunum, to the esophagus. He still have a stricture in the proximal esophagus, and they're still dilating it, and they're keeping a watch on it.
When we were doing these, Schlesinger and I were doing them, and then Scott Johnson came along, it was pretty rare. We always talked about the option of using small bowel and then have the microvascular surgeons go ahead and replant the artery into the aorta.
Yeah.
But actually, we never actually followed through with one of those procedures. Usually the colon. One of the things you have to make sure, especially in your veteran population, is the patient stops smoking. Scott Johnson will not consider doing a colon in a position in anybody who's still smoking.
Now be careful about the right colon. In 7 to 10%, the right colic does not exist.
Yeah.
So you may have...
That's what that swing up is based on, is the right colon.
Right, you have to be careful. You do an angiogram. We usually used to do angiogram first, just to be sure the patient does have a right colic, right colic artery. As you know, that's inferior pancreatic duodenal, right colic, mid colic, ileocolic. Yeah.
Highly variable anatomy, whether you have a right colic, two right colics, no middle colic. Dr. Hurd.
Are there specific surgical considerations technical when you're performing tracheostomy in the acute setting in these patients?
I didn't see anything specifically saying that about trying to, because really they're talking about late reconstruction, but I think in the initial evaluation, you need to get access to the airway and maintain it. And usually you're talking about maybe years later, this area those planes would be scarred in. And I think that's really what they're referring to. But nothing they meant technically you would do differently for a trach.
Any other questions for Dr. Nash? All right, thank you very much.
Thank you.